Aloha! This CME activity is jointly provided by the Queens Medical Center and UH-JAPSOM Department of Geriatric Medicine. We offer free continuing education for this series. In order to receive a CME or CEU, participants must complete the online evaluation at the end of the webinar. Your comments are very important to the planning committee and will be used to plan future programs. Health professionals, you can now check on your CME credits online. Go to www.queens.org and type CME in the search tool. Click on My CME Transcript, then sign in to generate your transcript. About ECHO, we want to remind everyone that this is an ECHO webinar, which means that this session serves as a forum for mutual teaching and learning from experts and from each of us on the front lines. As the ECHO motto goes, all teach, all learn. So it will take all of you to create this community of learning. In the spirit of aloha, we encourage you to turn on your cameras to help us build a community of learning. Feel free to eat during this ECHO session. Good nutrition is the key to a healthy lifestyle. A little bit about our format. After a short lecture from our experts, we will share expertise from the rest of the team and then open the time up for case discussions. We invite you to share any geriatric cases. It may even be on a topic not related to the topic of today's lecture. We only ask that you keep it HIPAA compliant case for discussion. That means, please do not share patient's name, birthday, address, and so on. We learn best from our patients. They are the best teachers. Our interdisciplinary team is here as well, and we are all willing to teach and share our collective wisdom with you. Most of you already know me. I am Juanette Gaylord, President of the Alliance of Residential Care Administrators, ARCA. We have Maribel Tan, President of Foster Family Homes Association. Elsa Talavera, President and CEO of All Island Case Management Corporation. May Magnayan, I probably messed that up, sorry May, nurse with Lokahi Case Management. Kira McCoy, Health Coordinator Lead at Aloha Care. Leila Ventar, Health Coordination Manager from United Healthcare, Kauai County. And Dr. Ritabel Fernandez from University of Hawaii. We are in the second month of our series on medications. If you're interested in viewing any of those lectures and handouts, you can find them on our website. Unfortunately, we cannot offer certificates of attendance for videos you have viewed. You must participate in our educational live. The title of today's webinar is Urinary Incontinence Medications in Care Homes, a Pharmacist's Guide. Now it gives me great pleasure to introduce our speaker, Dr. Reese Ueno. Dr. Ueno is a clinical pharmacist who graduated from the University of Hilo in 2013. Upon graduation, he established the Farm to Farm program at Kona Community Hospital. He was the clinical pharmacy manager for PharmaCare for several years. He presently is the clinical pharmacist at Kokua Kalihi Valley. He has served as a volunteer in the pharmacy at Queens Medical Center. Dr. Ueno has published articles on preventing medication-related hospitalizations. We are honored to have him speak to us today. Welcome, Dr. Ueno. Thank you.
Hi, thank you, everyone. Let me just pull up the slides. Okay, thanks. Okay, so today we'll be focusing on the urinary incontinence management in care homes from a pharmacist perspective with an emphasis on medications. Here's our objectives for today. We'll cover types of incontinence, medications that worsen symptoms, treatment options, prescribing, and sample cases as well. As an overview, incontinence is common and has significant impacts on residents and facilities. There's a high rate of urinary incontinence affecting over 50% of residents. So in many cases, each care home will have multiple patients suffering from urinary incontinence or UI. or in some care homes, all their patients may be suffering from some form of UI. In general, there's an increased rate of UI in women, patients with dementia, and patients post-stroke. In women, this is due to previous pregnancy, menopause, and other factors. In patients with dementia, this is due to cognitive and behavioral control over voiding or physically getting to the bathroom. In stroke patients, sometimes this affects their nervous system. Strokes may affect the nervous system, which controls their bladder and prevents them from voiding properly. Other impacts that UI causes is skin breakdown, falls, infections, and depression. For the skin, chronic exposure to urine increases moisture and disrupts the skin and causes dermatitis. And again, this may snowball and cause worse infections further down. In terms of falls can happen when patients are trying to rush to the bathroom. And as they're rushing to the toilet, they accidentally trip or fall. Oftentimes, when they're rushing, they forget to turn on the light. And maybe someone might have moved something in their way between their bed and the bathroom toilet. And again, it causes them to fall and possibly break a hip. And then there's many other issues that come from that. In addition to the skin infections, urinary infection risk can increase and patients may get UTIs. And lastly, patients may get embarrassed from their UI, which may lead to isolation and depression. And again, as you can see, all these UIs, it starts small, but then it can again snowball into much more severe issues for the patients later on. On top of this, UI leads to increased costs in terms of laundry, staff time, supplies. Again, more frequent linen changes, laundry pad, more laundering, more pads needed, and adult diapers needed. And lastly, in terms of regulatory perspective, there's CMS measures, state inspections, and I saw that there's some regulations requiring assessments and individual care plans for patients with UI. Over here, I have a brief review of the main types of urinary incontinence to help us link the drugs that we will be talking about and treatments to the right scenarios. On the top left over here, you see overflow incontinence, which is the retention and overflow leakage. So patients may dribble a little and they cannot fully empty their bladder. On the top right, we have stress incontinence, which is leakage with coughing, sneezing, or upon exertion, or sometimes physical activity may cause them to leak. Then on the bottom left, we have urge incontinence, when patients feel a sudden strong urge or overactive bladder. They feel like they have to pee immediately, and sometimes they don't make it to the bathroom. And then on the bottom right, we have mixed incontinence, which is a combination of stress and urge, or it could be a combination of other conditions causing UI. And then lastly, another thing that's not on here is functional incontinence. And this is when patients have limited mobility or cognitive barriers, and patients cannot physically make it to the bathroom, or may have dementia and cannot tell when they need to go to the bathroom. Excuse me. Okay. So many common medications can worsen bladder control, and it's important to recognize these as they're critical before adding bladder-specific medications for UI. Again, UI can be made worse by several meds that increase urine production, such as diuretics like furosemide. I'm sure many of you have patients on furosemide. Also, medications that cause outlet relaxation, like alpha blockers, such as tamsulosin, again, a very common medication in our population, or medications that cause nerve interference, such as antidepressants, antipsychotics, or sedatives. And then also medications that cause sedation, medications such as benzodiazepines like lorazepam, Ativan, or other antipsychotics maybe that are being used on a patient to sedate them or help them sleep through the night. All of which may impair continence by affecting the bladder function, sphincter tone, or central nervous system control. Some practical strategies for managing medication-induced urinary incontinence involve maybe adjusting time of the diuretic administration. Like furosemide, we usually recommend patients to take it earlier in the morning. If it does require twice a day dosing, maybe instead of taking it at night at 6 or 7 p.m., maybe taking it in the late afternoon to have it go into full effect while the patient is awake versus in the middle of the night. Also, you can lower the risk of medications by deprescribing medications when possible, especially in the context of polypharmacy and multi-morbidity. Regular medication review and individualized risk-benefit assessments are essential in catching these medications that maybe need to be optimized or discontinued or adjusted. In addition to medications, non-drug strategies remain the foundation, even when medications are used. As always, staff should integrate these measures into care plans. Firstly, scheduled toileting or prompted voiding, recommending patients go to the bathroom on a set schedule. Sometimes fluid management, limiting fluids, again, only if appropriate and approved by their doctor, maybe not letting patients have multiple glasses of water right at bedtime, maybe spacing it out throughout the day may help. Pelvic floor exercises, environmental adjustments can be done, such as clearing the path to the toilet, improving visibility of the toilet to the patient, as well as night lights or things to light up the hallway during the evening. And then lastly, incontinence briefs as a supportive measure. So going into the medications are always adjuncts to non-drug approaches and must be chosen carefully in the elderly. The goal is to reduce urgency, frequency, and improve quality of life. It's important to remember UI meds are not a cure. Benefits need to be balanced with possible side effects. Risk benefits always need to be thought of. So firstly, antimuscarinics are the first line for most patients, especially when you consider their drug formulary. But it is also risky in the elderly, which many of our patients in the care homes are, especially with those patients with dementia. Some examples of antimuscarinic medications include oxybutynin or tolterodine. All antimuscarinic drugs act by blocking muscarinic receptors in the bladder muscle, and then it reduces the involuntary bladder contraction, which improves symptoms of urgency, frequency, and urge incontinence episodes. The most common adverse effects are dry mouth, constipation, and blurred vision and confusion, with the risk of cognitive impairment being particularly relevant in our older adults. So sometimes giving a patient an extended release or transdermal formulation like a patch are preferred in the elderly to minimize peak plasma concentrations and reduce the side effects, especially with dry mouth and CNS or central nervous system effects. Immediate release medications like oxybutynin is specifically discouraged in frail older adults due to this high risk of anticholinergic effects and cognitive impairment. Some of you may be more familiar with the brand names like tolterodine is Detrol or oxybutynin is Ditropan or Oxytrol. And I would say oxybutynin is probably the most common medication that I see in our practice that's being used for UI. And as I mentioned again earlier, oxybutynin is usually the preferred first line medication per insurances. some of the other medications that we'll discuss later on will often need a prior authorization or a PA with the physician, just to find why maybe the oxybutynin is not appropriate or a patient tried and failed it. Moving on to the next class of medications, the beta-3 agonists. These are great alternatives in patients with high anticholinergic burdens, but the blood pressure needs to be monitored in those patients. Mirabegron, it's a beta-3 agonist used for the treatment of overactive bladder. And the mechanism of action involves stimulation of beta-3 receptors in the detrusor muscle, leading to relaxation during the storage phase, and thereby increasing the bladder capacity and reducing urgency and frequency. The benefits of these agents include efficacy comparable to antimuscarinics for reducing urinary frequency and urgency incontinence, along with a lower risk of cognitive adverse effects such as confusion and dementia, which is more commonly associated again with the antimuscarinics on the previous slide, especially in older adults. A few risks that we do want to consider if your patients are on these medications. Some of you may know it as Geriatric. Risks include increased blood pressure or hypertension, headache, and urinary retention. So in particular, so if your patient does have a history of hypertension or high blood pressure, you want to make sure that you're checking their blood pressure regularly as they start off on this medication, and to inform the provider if there are any changes or unhealthy increase in the blood pressure. For example, some of the studies I saw, I think the average is about 4 mmHg for systolic and 2 diastolic is added, so which in many patients would be fine. But I think maybe in a smaller study, about 20% of patients had an increase of 10 mmHg for systolic. And that's something that you'd want to watch out for if your patient is one of the 20% of patients that have it increased by that much. The next class of medications we're going to go over are the alpha blockers, which are effective for overflow incontinence and BPH in hand, but they do have a risk of increased falls. So medications that are alpha blockers include tamsulosin and alfuzosin. I'd say tamsulosin is probably one of the most common ones that we see patients on. Again, male patients for BPH. And the mechanism of action is to block the alpha-1 receptor in the smooth muscle of the bladder, neck, and prostate. And this relaxes muscle to allow for the bladder outlet resistance and increase urine flow. Again, the main risk with this medication is primarily with orthostatic hypotension. So that's when a patient goes from sitting down or laying down to getting up. They might get lightheaded or dizzy, which would increase their risk of falls. So if a patient were to start on this, on tamsulosin or alfuzosin or terazosin, for example, you should double check them, and help them when getting up and monitoring them for those dizzy spells.
Dr. Wano, you're talking
Yes.
about Flomax, right? The Flomax
Yes.
medicine? Okay.
Exactly, yeah. Flomax would be the trade name. But I would say, no longer available. So most of the time you'll see it as tamsulosin. Around the bottom you may see also known as, Flomax. It's very popular, very popular. Okay, moving on to the next class of medications are topical estrogen. Generally safe in our population. And typically used in postmenopausal women to treat UI. And the mechanism involves restoring the urethral mucosa, increased vascularity, and improvement of local tissue environment, which can reduce lower urinary tract issues and symptoms of urgency, frequency, and incontinence. The main risk of the local estrogen therapy are pretty minimal due to the low systemic absorption, or when you apply the cream or lotion in the area, it's mostly being absorbed in that specific vicinity. Very little of that estrogen is being absorbed into the full body, but you do want to take note of any patients with a history of like cancer, like breast cancer, for example, and double check with their doctor about the patient's history if they are going to try topical estrogen. And then lastly, duloxetine. I have listed over here that it's off-label in the US, so it's not FDA approved. It is approved in the European Union, and some doctors may still prescribe it for our patients over here. Duloxetine is a serotonin or norepinephrine reuptake inhibitor, or SNRI, that increases urethral sphincter activity by enhancing neurotransmitter levels in the sacrospinal cord, thereby facilitating the sphincter contraction during urine storage. And it reduces stress in UI.
This is Cymbalta, right? Duloxetine is Cymbalta?
Yes, correct. And the main reason why it's not approved in the US for UI is its psychiatric adverse effects in our patients. So this could be nausea, insomnia, hypertension, or even serotonin syndrome. So I think, for some patients, the benefits don't outweigh the risk of this happening in the patient. And that's why it's not FDA approved. But again, for a specific subset of patients, this may be very beneficial and helpful to them. So you may see this in some of your patients, especially if they've tried maybe some of the other previous medications and nothing worked. So, the physician may go down the line and end up trying this, and if nothing is really helping or improving their symptoms. Okay. The prescribing and medication review. As we discussed, meds that we may use, deprescribing should also be considered as an effective tool to improve outcomes without adding drug burden in our patients. So you should always check for reversible causes before adding UI medications, such as we mentioned earlier, diuretics. Also, we want to reduce polypharmacy for better cognition and mobility, such as reviewing their patients with antipsychotic medications, pain medications, or benzo medications. And again, we should always collaborate with prescribers to taper harmful medications and check off those boxes, again, before adding UI medications. So monitoring and follow-up. It's important to, if your patient does start a UI medication, it's important to use bladder diaries or incident logs to track if the medication is truly improving your patient's daily life, or maybe if it's making it worse, so you need to double check their blood pressure for side effects, right? Cognition, right? That's a very common one in the antimuscarinic medications, constipation, dizziness, again, the most common. And it's also important to reassess the medications after 4 to 8 weeks or 1 to 2 months. Because at this point, if the patient doesn't seem to be improving in their UI, then the patient is not getting the benefit from it, and discontinuing the medication may be the best option for the patient, and trying something different, or maybe doing some non-pharmacological things, as we discussed on an earlier slide, may be better. And again, because it's not a cure. You always have to reassess and make sure that the benefits are outweighing the risks of the medications. So I have 3 case studies that we can all go together, and I can open it up for a little bit of discussion. So in case 1, I have an 88-year-old female with dementia with urgency on oxybutynin IR, which is immediate release, and furosemide twice a day. So do I have any takers on maybe what would be something we'd want to adjust or double check with the physician to help optimize their therapy? And I do want to mention there's, more than one answer to each of these cases. There's no one answer.
Hey, Dr. Reese, my name is Gabe Vega. I'm with the Aloha Care team as the chat facilitator. I do have a quick question for the first case. Since this is a patient that does have dementia, would timing be an important factor, especially with oxybutynin? Maybe not
Yes.
taking it at night. Okay, for incontinence.
Yeah, that's great. Yep. So again, patient has dementia, they're on oxybutynin and antimuscarinic. Confusion it may make it worse, right? And again, oxybutynin IR, it's immediate release. Oftentimes, maybe extended release version may be beneficial to the patient so that there's not so much of a peak in the drug concentration. Also, in this patient, they're on furosemide twice a day. As you mentioned before, furosemide, it works by, again, it's a diuretic. It's causing them to go remove their extra fluids. So maybe moving the furosemide earlier in the day, maybe in the morning, right when the patient wakes up, maybe mid to late afternoon for their second dose. And then that way, it's not the furosemide, which is called Lasix. So Lasix, because it lasts 6 hours, is not going into full effect throughout the night while the patient is sleeping.
Okay, thank you so much, Dr. Reese. Does anyone else have any follow-up questions for these case studies?
We can move to case 2, 82-year-old male with BPH on tamsulosin and has been having nighttime falls.
He would need supervision, right? Or do we discontinue the tamsulosin? But he needs it, right?
Yeah, so in this case, you got it right. So the tamsulosin is definitely needed for this patient. Maybe we might want to try a different alpha blocker, for example, or we can adjust the timing of it. We don't have when the patient is taking the tamsulosin. So if they're taking it at night, we could try taking it in the morning, or vice versa. If they're taking it in the morning, we can try to move it to the night. Also with the frequent nighttime falls, we can do some non-pharmacological approaches, make sure the path to the toilet is well lit, that there's nothing blocking it, before the patient goes to bed. Maybe putting some other supportive measures, from the patient's bed to the toilet area as well. Yeah, bedside commode. Yep, very good option right there. Urinals. Yep. And then we can move to case number 3, 90-year-old female post-stroke on amitriptyline for sleep. Is having UI. So maybe again, in this patient, she's an older adult on amitriptyline, which is a TCA. You might want to consider deprescribing. sometimes less is more, right? So taking it off of the patient's medication list, and then try some non-drug sleep interventions, reassess the patient's bladder symptoms. Maybe the patient is, if they need the amitriptyline for sleep, maybe if we can change some of their sleeping habits, like if we notice the patient is napping a lot through the day, maybe if tolerable, less napping around the end of the day, so that the patient can have a more restful or go to sleep a little bit quicker in the early evening. Maybe limit screen time late at night in the patient as well. But yeah, any other thoughts on these cases? I mostly put them in as a discussion, if anyone has any other input.
Doc, how do you feel about melatonin?
Yeah, I think that's very, for sleep in older adults, yeah, that's a great option. It's very, I would say, overall very safe and mild in the patient. So I know some patients that melatonin works really great, even at 1, 2, or 3 milligrams. I know some patients that may get more benefit from 5. And again, there's some patients that don't get as much benefit even when they try the 5 milligram or even the 10 milligram. But I think it's a very non-invasive, non-intrusive, over-the-counter medication that the patient can try, especially, of course, with double checking with the provider as well. And it's very cheap and a cheap alternative too, right? You can get like 100 tablets of melatonin for a few dollars in many cases if you get the store brand.
So if the melatonin doesn't work, what other options would you suggest?
To help this patient with sleeping.
Correct.
And we already tried the non-pharmacological approaches already.
Right.
Yeah, that's a tough one. We'd want to look more into this patient's like theoretical past medical history, right? Before we think of other medications. Because I would say in many cases, when you get up to this age, there's no one best sleep aid medication, we'd want to recommend for all patients. So, trazodone, some people may try, but again, there's some risk with that medication as well. Mhm.
Thank you.
Dr. Reese, we have a question in the chat from Renata, asking if you can comment on third spacing for dehydration or chronic inflammation, post-op fluids, etc.
That I'd have to look more into. Yeah, sorry about that. I don't have
No
an immediate
worries.
answer to that. I can get back to you.
And then there's another question here. For having dementia with trazodone and escitalopram, is that okay for routine, not causing UI? From Marianne.
Mhm. With escitalopram and trazodone in a patient, let me try to see if I can
Having dementia.
I mean, I would say for that one, it's very case by case basis, right? For the patient with the trazodone and escitalopram, were they both started at the same time? Was it both initiated by the same provider? These are very good questions to review when you do a medication therapy management review. Just both at the same time. Again, those medications don't go into effect exactly at the same time. So if you're worried about just giving them at the same time, I wouldn't be too concerned with that. Especially if the provider feels like it's okay for them to take throughout the day, because another option is you could put the escitalopram in the morning or earlier in the day, right? That's the option. Some patients take it in the morning if you wanted to adjust it. Any
Looks like
other
we got
questions? Yeah, go ahead.
we have a couple more here in the chat. Gabapentin and trazodone can cause incontinence too. Question, patient have dementia as well, by Ellen Rispio.
Yeah, these are very tough questions. Whenever you have a patient with dementia, you know, it's always tricky. You know, some patients it's appropriate, some it's not. Again, I'd have to look at the timing of when the medications were prescribed, when they were started, you know, because when we look at polypharmacy, often it's just a slow addition of medications, right? Like 10 years ago, a patient was on 5 medication. Over time, it grew to 8, 9, and 10. And then some people, just because they've been on these 8 medications this whole time, they don't really want to shake the boat too much. And they just continue to add. But it's good to at least maybe every quarter or every half year, if medications are changing frequently, is to go through the med list with the PCP or the pharmacist at the pharmacy that you're getting your medications from, just to make sure that the medications don't have a strong interaction, right? Again, gabapentin and trazodone, it'll cause the patient to get tired, you know, but incontinence, if the patient didn't have incontinence and they started having incontinence after those medications, then yeah, I would consider that to be a reason or a factor to it. But hard to tell without getting more background information on this patient. And again, this patient has dementia too, so it's difficult.
We have another question from Leilani. Few meds for UI. Are there anything for fecal incontinence?
Yeah, there's a few medications that's a little bit outside the scope of this presentation, but there's some medications for GI symptoms. It depends on, again, what the root cause is. And then depending on the root cause, then maybe there's some medications out there to make it, to help the patient stay more regular, for example. And then by the patient being more regular, it'll help with fecal incontinence. Or I had a question for everyone, you know, for your patients that do suffer from incontinence, where do you get your supplies from? Does anyone ever have issues or maybe with getting insurance to cover it? What kind of workarounds have you developed?
Well, majority of the care homes, insurance does not cover it. People who have other type of benefits, obviously Medicaid, then they do have benefits for the incontinence supplies. But as far as independent care homes, we usually have different companies that we deal with to get our incontinence supplies, or you can buy it from Sam's Club, Costco.
Thank you.
Dr. Reese, could you explain time toileting in a little more detail so everybody understands what is time toileting?
Yeah, so I believe just time toileting, and I believe it's referring to just setting a schedule for patients. So maybe scheduling them every hour, you know, having them leading them to the bathroom or commode or wherever they go to the bathroom, and just keeping it consistent. And then hopefully by doing that, it'll, you know, help with managing their UI issues. And then you can track it down in a diary, as I mentioned before. And then that's how you can talk it. Yeah, it's a lot. Yeah. So maybe, you know, time toileting, it could be every 2 hours or 3 hours, whatever you feel is appropriate. Again, working with the provider and how severe the patient's UI is. And, again, each should assess the practicality of it, right? Because it is a huge burden on the caregiver, especially, you don't just have one patient, you have three or four patients possibly, or some of you may be in a much larger care home environment.
So, Dr. Reese, it looks like we have a question from Renata on what type of supplies from your initial question.
Yeah, so this is referring to like adult diapers or the pads for the patients, that you put on the bed. I guess because when I was reviewing the topic, I saw numbers such as $900 or great more than $1,000 or $4,000 in some cases. That's again put on the care home or caregiver for patients, and those are extremely high costs. Especially if it's not covered by insurance or um, how you're helping the patient, right? Or if the patient doesn't pay for it, their family, the cost would move on to them, right? And that's a significant amount.
Thank you so much, Dr. Reese. Do we have any more questions from the chat?
Dr. Reese, could you explain Kegel exercises? What are Kegel exercises?
Yeah, I'm not expert, but it's practicing. Oftentimes I believe they sit on a chair and then they, yeah, like Marianne mentioned, it's bladder control. So they work on like the pelvic floor and trying to exercise the pelvic floor so that they can control their bladder a little bit more. I believe it. A lot of women, after giving birth, Kegels help significantly with UI in that population. And again, as you get older, for stress incontinence, it's very beneficial to work on that and to do that. Oh yeah, thank you, Renata. Yeah, starting and stopping urine flow is an example that you can practice on as well, or that the patients can practice on. Okay, any other questions?
Looks like that's it for now, Dr. Reese. Thank you so much.
John, maybe you can bring up our evaluation slides, please. Juanette, would you be able to explain the evaluation slides and how to get the CME credit?
Most definitely. John, are we able to get it on for everyone to see?
Yes, it's on there.
Oh Lord. Okay, I don't see them. Let me try to see if I can find it. Is it on the screen for everyone to read as I go along?
Yes.
Okay. Am I the only one who doesn't see it? Does everybody else see the screen with the questions?
I can see it. Mm-hmm.
Okay, you know what? Because I can't see it, I'm just going to go over it. So basically, you have to put in your email address, first name, last name, fill out all that information on you, your background, and how the presentation is. That's as far as the first page of the evaluation. And then it goes on to ask you to fill out per resident that you have in your home. So the very first one you want to fill out is for your resident that has been with you the longest duration of time. So that's for the first one, and answer all the appropriate questions. Again, I apologize, but I can't see that screen. Can someone else tell me what's on that?
I can see the screen and I'll explain. So this is medication evaluation. We need to look at medication evaluation for all the residents in the care home or foster home. So you're going to look at, has the resident been prescribed medication for pain, and has it been reviewed by doctor? Yes, no. If they have been prescribed medication for sleep, has it been reviewed by doctor? Yes, no. If the resident was prescribed medication for agitation, has it been reviewed by a doctor? Yes, no. Has a brown bag medication review been performed? Yes, no, not sure. Was the medication list updated? Because what we are seeing is residents see so many doctors, so many specialists, that medication review is very important to make sure that they are taking the correct medicines, and the ones that they don't need have been stopped. So this evaluation is looking at medication list and whether it has been reviewed or not. So these questions will come when you do your evaluation. Next slide, please. Okay, this is how we receive a certificate for attendance. Every person got to fill it out, and we cannot give out for watching the videos online. It has to be people that have attended the live session. Next slide, please. And we want to say mahalo to each and every one of you. We know that this is not an easy job, especially when we have residents who are incontinent. It is not easy caring for them, and we thank you for your love and for your aloha and everything you're doing for your residents. Big mahalo, and thank you for attending our sessions. We have the evaluation link in the chat. Please fill out the evaluation. And Dr. Reese Ueno, this was a fantastic presentation. It's a topic that we rarely speak about because it's an embarrassing topic, and you covered it so beautifully. Thank you for discussing all these pharmacological, non-pharmacological methods for urinary incontinence and teaching us about the side effects. We appreciate your teaching us all these wonderful things on this topic. Thank you, Dr. Reese Ueno.
Thank you, Doc. Appreciate all your time and efforts put into this presentation.
Yep, it was a pleasure. Thank you.